How's it going there, class? This is going to be our week 14 lecture on childhood disorders. This is going to be the final lecture for this semester. So let's go ahead and get our slides ready. Let's go ahead and get ready to take some notes. Don't forget to watch the study videos on Compass, and then email me if you have any questions. So here's our agenda for today. It's actually pretty lengthy, but it'll probably go by pretty quickly. But please, if you need to take a break every now and again, you can go ahead and take a break each of these time points. So we're going to start by talking about childhood disorders in general. Then we'll go talk about autism, epidemiology, diagnosis, and treatment of autism. We'll talk a little bit about adults with autism spectrum disorder. Then we're going to talk about ADHD, a little bit of epidemiology, a little bit of treatment, adults with ADHD, and make some comments on the increasing rates of ADHD. So childhood disorders are often first seen in childhood, and they're ideally diagnosed in childhood, but they do affect individuals as they become adults. So these are usually detected first in school settings, and this is because this is a situation where the children are being monitored on a constant basis, and so any kind of behavioral issues or comparisons between other children in their age range will become more prominent, or should say pronounced, when a child attends school, daycare, etc. Once a childhood disorder has been detected in a school setting, it's usually monitored through pediatric appointments. And what this means is that the pediatrician is going to perform tests, check the progress of the child, to try to see if this is really any kind of developmental issue, or maybe it's just normal behavior that just doesn't seem developmentally appropriate at the time, but actually is. So these disorders are going to affect individuals throughout their lives. So for example, if you have ADHD, you really don't age out of ADHD. Usually you learn different kinds of strategies and skills, or maybe medication management, to live a normal life with your ADHD. And the same thing goes for autism spectrum disorders. So really, when the individual has this disorder, even if they're not diagnosed, they can still suffer from it later in life. So this is usually why it's best to have the diagnosis in early childhood to try to help the children get through school, because once you're an adult, you can probably still receive help for any kind of issue that you had from childhood, but it's best to make sure that you identify this early. That way you can help a child still meet the educational milestones that they're required to do. Now, just because these disorders are usually better identified and treated in childhood doesn't mean that there isn't a need for treatment and support as an adult. So it's important to raise awareness and destigmatize these childhood disorders, to let people know that they also persist through adulthood, to try to help individuals who may have slipped through the cracks as children to still achieve what they need to achieve as adults. So when it comes to autism spectrum disorders, we often talk about, well, actually for most mental disorders, we talk about person first versus diagnosis first language. So this example of this is, I could say a person with autism, and this is a person first language. And some people might say an autistic person. And this really depends on the individual, what they prefer to be referred to as. So as somebody who is an outsider looking in, it's not necessarily the best idea to determine for another person how they refer to themselves. So for example, I am a black man, but some people call me a person of color, and I prefer the term black male. So does that mean that all black people prefer to be referred to as a black people? No. Some prefer to be referred to as a person of color. So it depends on the individual. So sometimes you might misidentify an individual and use the wrong language, and then you just say, "Oh, I'm sorry, what would you prefer?" But it's never the right thing to do, to be like, "You need to stop. You need to be person first all the time. Diagnosis first is terrible." We're trying to move away from solely using diagnosis first, because there is a stigma attached to dehumanizing the person by putting their diagnosis first. However, the individual might prefer to have the diagnosis first. So, for example, I'm also an alcoholic, right? So a lot of times I'll refer to myself as an alcoholic or as an addict, rather than a person with alcoholism or a person suffering from addiction. But these can be interchangeable. And some people might be offended by the use of those terms, and also some people might not be offended by the use of those terms. So it depends on the person. So yes, there is a difference between person first and diagnosis first language. Usually the problem was that the individual making the diagnosis, the individual from a position of power, was labeling other people. Nowadays, people have the ability to label themselves. So if somebody tells you, I'm an autistic person, do not correct them. They identify as an autistic person. And we also have the term neurotypical. So neurotypical, in regards to autism spectrum disorders, refers to individuals without autism spectrum disorders, or individuals who do not have any other types of psychopathology if you think more broadly. So for example, you might have depressed individuals or individuals with depression. And then you have neurotypical individuals, which are individuals who don't have depressive symptoms. So neurotypical is this range of behaviors which is seen as normal, acceptable, what's within the appropriate variance. And then if you exist outside of that, they would be neural atypical or, as we'll talk about later, neural diverse. And then also we want to talk a little bit about the differences between developmental disorders and neurological disorders. So developmental disorders these are usually disorders that kind of affect usual developmental processes. We're talking about things like language, and the intelligence quotients, IQ, motion, cognitive processing, etc. So these kind of things really present themselves in early childhood, because as you're developing, as you go into adolescence, as you go into early adulthood, this is where developmental disorders come into play. And these developmental disorders can have lasting effects, but also you can make accommodations, you make adaptations to try to lessen the dysfunction caused by these disorders. Now, when it comes to neurological disorders, it's a little bit different. This is going to be disorders that affect the brain or the process or the neural process. So these kind of disorders might be a little bit harder to treat because you're talking about brain structure, you're talking about brain chemistry, you're talking about the way neurons work. So for this one right here, these kind of issues will be more chronic in nature and be more persistent throughout adulthood to a more severe degree. And there's less of a chance, not to say that you can't be treated, not to say you can't be helped, there's less of a chance to receive better outcomes or improved outcomes with a neurological disorder. So when we talk about autism spectrum disorder is characterized, it used to be characterized with deficits in social ability, communication, and with restrictive or repetitive behaviors. And this usually included an average to below average IQ. So we're talking about IQs of 100 or less, and often with deficits or absence in spoken language. Now, there was a similar diagnosis to autism spectrum disorder called Asperger's, but this included people with average or above average IQ and often had very formal or advanced language. So this is back in the DSM-4. This is before the DSM-5. So remember, DSM-5 is 2013. So like 2012 and before, autism spectrum disorder was one thing, and then Asperger's was a whole different thing. Now we have Rett's disorder, which is a mutation on the X chromosome. So this would entirely affect females. And then this led to serious neurological impairment and autism spectrum-like disorder symptoms. And so now that we know that's more of has to do with a gene dysfunction, it's not really included as a DSM behavioral criteria. And then there is childhood disintegrative disorder or CDD. And this is when you were like 18 months or so, you had normal functioning, right? So up until about a year and a half of age, everything was going well. But then later on, you started to miss developmental milestones and you started to regress into autism spectrum disorder type of behaviors. So right here, most of these individuals would now be characterized as having an autism spectrum disorder. So we're talking about the classic autism, we're talking about the Asperger's disorder, we're talking about the PDNOS disorder. These are all things that used to be considered different types of autism, but now they're just on the spectrum. Now, The Rett's disorder and the childhood disintegrative disorder, these are no longer in the DSM-5. So autism spectrum disorders are more inclusive, more encompassing, but also destigmatize and better explain the range of behaviors and dysfunctions that could be present on autism spectrum disorders. And also it kind of removes the Asperger's category. Now, does this mean that people don't say Asperger's anymore? No, people still say Asperger's. So remember, as a field, 2013 and up, we don't say Asperger's anymore. We talk about autism spectrum disorder. But you might watch television shows. You might watch, you hear people still refer to themselves as being Asperger's or being Aspies or things like that. If you watch like a show like Love on the Spectrum, you might hear this a lot. But Asperger's is not something that people have anymore. It is within the spectrum of the autism spectrum disorders. Now, even though we generally do not associate or automatically associate autism spectrum disorders with reduced or lower IQs, 56% of individuals, or I should say children, with autism spectrum disorder have below average IQs. That means less than 100. All right, so here's a little bit of review for you. So how many autism diagnoses now exist in the DSM-5? Is it A, 1, B, 2, C, 3, D, 4, E, 5? All right. There we go. It's going to be 1. Remember, we have autism spectrum disorders, which encompasses a wide range of behaviors, symptoms, and dysfunction. All right, so it's important to make some distinctions when we're talking about autism spectrum disorder. So we're going to talk right here about a lot of symptoms, a lot of impairment, a lot of mile markers that you might want to look at to try to see if someone might have an autism spectrum disorder. But it's very important to understand that if you've seen one person with autism, you've seen one person with autism. Some people don't know what that means. Let me explain it a little bit better for you. If you've seen one person with autism, that doesn't mean that another person with autism will have the same behaviors, the same patterns, the same symptoms. That means it's going to be totally different. So when we're talking about autism spectrum disorder, it is extremely heterogeneous in nature. What does that mean? There's a lot of differences. So I would encourage you to go to the DSM-5, the chapter on Compass page, and then read through the different criterion, read through the different symptoms, and get a better understanding. Look at some of the differential diagnoses, look at some of the other information present for you. If you have questions, send me an email. But for criterion A, you want to have persistent deficits in social communication and social interactions through all of the 3. So this is going to be deficits in social, emotional, and reciprocity. So this is going to be like abnormal social approach and failure of normal back and forth conversation. You might have a reduced sharing of interests, emotions, or affect with other individuals. And then you might have a failure to initiate or respond to social interactions. You're also going to have deficits in nonverbal communicative skills or behaviors. So this is going to be things that are important for social interaction, like you might have poorly integrated verbal and nonverbal communication. You might have abnormalities in eye contact or body language, or deficits in understanding the use of gestures. And you might even have like a complete total lack of facial expressions and nonverbal communication. And then deficits in developing, maintaining, and understanding relationships. This could be ranging from, example, difficulties adjusting to behaviors that suit various social contexts, to difficulties in sharing imaginative play or making friends, or to the absence of interest in peers. And for our criterion B, we're looking at restrictive, repetitive patterns of behavior, interests, or activities with at least 2 of the following. You got stereotype or repetitive motor movements, use of objects or speech. So for example, this could be like, simple motor stereotypies. Maybe you're lining up toys or flipping objects. Then you have the echolalia and idiosyncratic phrases. You can also have an insistence on sameness, inflexible adherence to routines or ritualized patterns of verbal or nonverbal behavior. So for example, this could be extreme distress at small changes, difficulties making transitions, rigid thinking patterns, rigid greeting rituals, or the need to take the same route or eat the same food every day. You could have highly restricted fixated interests that are abnormal in intensity or focus. So for example, you might have like strong attachment or preoccupation with unusual objects, excessively circumscribed or perseverative interests. And then you also might have hyper or hyporeactivity to sensory input, or unusual interest in sensory aspects of the environment. So, for example, you might have impaired indifference to pain or temperature, adverse response to specific sounds or textures, excessive smelling or touching of objects, visual fascination with lights or movement. Now, when it comes to the duration of these symptoms, it's very important that you detect these early in life. So these symptoms must be present early in life, but they might not show up until later on. So a lot of times when individuals are being screened for autism spectrum disorders, there's going to be a lot of self-report measures or observer report measures that might ask individuals to report how this individual behaved earlier in life. And this is usually how you would determine whether or not someone demonstrated or exhibited these symptoms at a younger age. For example, if you're to assess somebody who was a teenager or an adult. So there are some specifiers with autism spectrum disorders. Now, it used to be that people would say high functioning or low functioning when talking about autism spectrum disorders. But now it's a little bit different. So we talk about different levels of dysfunction, different levels of support. So right here we have level 1, which is requiring support, level 2, which is requiring substantial support, and level 3, which is requiring very substantial support. So this depends on the individual's need of additional care from other people. So, for example, you might think about somebody who is more on the, see this right here? What I'm doing here? The Asperger's side of the autism spectrum. That doesn't exist anymore. I'm just telling you like this. Okay. So like that. So if somebody who maybe requires less support, somebody who maybe has some rigid social behaviors, some problems with relationships, but they have above average IQ, they're very articulate, they're very verbal. You might have somebody who is nonverbal, who does not have really good communication skills. So that person might require more support, more substantial support. And then you have somebody who's completely nonverbal. There's a lot of behavioral issues. It's really hard. They can't take care of themselves. They can't support themselves. They need more care. And so we have different levels of support for autism spectrum disorder. Now, these levels, you can fluctuate over time, right? And these levels might change depending on the context. So you could have somebody who's very successful at work, but maybe they have more problems at home and in relationships and with family members, etc. And vice versa. Maybe you have somebody who's really good at home, but it's really bad at school or really bad at work, or maybe somebody who has deficits in all those different areas. But like I said before, if you've seen one person with autism, you've seen one person with autism. So this can all depend and this can all change over time. All right, here's a little bit of review for you. So Abigail is 6 years old and loves CVS Pharmacy. She spends most of her time discussing CVS Pharmacy, drawing their logo, and begging her parents to go to CVS. She has large-scale meltdowns if your family drives past a CVS Pharmacy without stopping. Her love of CVS Pharmacy best falls into which category? A, social and communication deficits because she will only discuss CVS. B, restricted repetitive behaviors because of her restricted fixated interest in CVS. C, both. D, neither is not actually a symptom. Okay, take a look at the options here. What do you think? Answer is B, restricted repetitive behaviors because of her restricted fixated interest in CVS. That doesn't make sense to you? Please come to office hours. Please send me an email. All right, so here's some epidemiology on autism spectrum disorders. So 1 in 59 children by age 8 have been diagnosed with or meet criteria for autism spectrum disorder. About the ratio between males and females is 4-1. Now this used to be a lot different. So it was like 5-1, 6-1, but then now it's starting to become a little more equal. Now, individuals or researchers think that this is also because of higher prevalent rates in males, but also it's easier to identify in males and females. So as diagnostic instruments get a little bit better, a little more precise, we're able to detect autism spectrum disorders in younger females. And so socialization plays a role in this as well. So females are socialized to have better social skills And so then they have fewer externalizing symptoms. This is also known as the female protective effect. And so this would help young females to fly under the radar, whereas the young boys, they're going to be doing different things. All right. So this also affects all races, all ethnicities, all cultures, and all socioeconomic classes. And these diagnoses might be received in a different method. So, for example, people from different socioeconomic backgrounds or different cultural backgrounds might have these symptoms identified in school or identified in childcare, whereas other individuals might actually seek out a screening. So they might notice something in their child and then pay out of their pocket or through insurance to receive a diagnostic screening for autism spectrum disorders. So it affects people across the spectrum, across the board, in a variety of different backgrounds. However, some individuals have better access to treatment, access to screenings, access to support. All right, so right over here, we have a video that's going to be talking about females with autism. So I'm going to go ahead and jump out the way. I'm going to let you watch this video and let my YouTube channel get demonetized. And then when the video's over, I'll jump back on and then we'll talk about it.
When people think of a disease, they think of something that is degenerative and that will hurt you and kill you. Autism is not a disease. It is a developmental disability. It's about living our best possible lives with this condition.
I don't know, I always get the you don't look autistic thing. Autism is like an internal thing, not an external thing. No one looks autistic.
And people find that out, the first thing they're like, you don't act autistic. And I'm like, I had to go through a lot of stuff to learn how to mask my idiosyncrasies.
Autism isn't a linear spectrum of high or low. It's a whole bunch of different traits that are on their own spectrums. That's kind of a 3D weird mess.
Autism is simply a different way of thinking and seeing and interacting with one's world. I view autism as realness.
The words high functioning and low functioning are used by people, again, who are talking about autism from an outside point of view. So rather than using those labels, we tend to say minimal support needs and high support needs to describe the different kind of levels of the spectrum that people fall on.
I definitely would disagree with the idea that we're not emotional. I think we're actually highly emotional. I think that many times we don't express it the way that people expect.
I like the comparison to Vulcans. In Star Trek, lore, the Vulcans feel more strongly than humans. They just, don't show it.
We're feeling it. It's there. It just might not come out. And then other times it might be overly expressed.
I mean, sometimes, we'll cry. I mean, that might be at, weird moments. I mean, you might think they're weird. I don't think they're weird.
It can be so overwhelming, so intense that in order to function, you kind of have to sort of be still or shut down a bit.
We can't filter them out because we feel them so strongly, so we shut down as a way of processing all those emotions.
It takes a lot of effort to appear the way I do right now. It takes a lot of conscious awareness. Social skills are like a muscle for us.
People will often say to me, "Oh, you're so high functioning, I would never know you had autism unless you said something." And I say, well, you don't live inside my skin, and you don't know how hard it is for me sometimes just to get through a day.
It's very, very draining. Even with people that I care for or enjoy being around, I have to psych myself up to be around them.
All the little things that everyone does unconsciously, autistic people do manually, so that adds up. What I'm doing with every part of my body, I am to some degree aware of and trying to do.
A lot of women that I know who are autistic are not diagnosed until their 20s, 30s, or even beyond. A large part of this is because the way that we diagnose autism is by using criteria that were created observing boys. And autism looks different in girls and women than it does in boys.
People don't expect to see someone that looks like me or my two youngest children who are on the spectrum also. We know that anyone can, be on the spectrum.
I didn't become aware of Asperger's until I was already an adult. At the time, finding a doctor was really difficult because there were people that were like, oh, women don't have that. And then there were other people that were like, well, you're too high functioning.
I was in my early 30s when I was diagnosed myself. After my children were, I don't think I would have been otherwise. Women are underdiagnosed, Black women especially, and I think there's also this idea of, the strong Black woman. You kind of have to hold down the family and be able to just keep going and not address, your, whatever needs that you have, your support needs, not prioritize self-care. We just kind of slip through the cracks through the majority of our lives.
I remember parent-teacher conferences of teachers telling my mom that I should be in special ed, I was an ideal homeschool candidate, there was something wrong with my brain. I remember that one, that was cool.
And now I feel a lot better. I feel like, okay, I know why I'm this way. I know why other people are the way they are, so I can bridge this gap.
You invite a girl back to your apartment to watch a movie and she thinks you're just watching a movie. Netflix and chill doesn't literally mean Netflix and chill. That often does happen when you have someone who is inherently a little bit more naive because they're so literal.
When we think of people on the spectrum as not being interested in sex, not having any kind of sex drive or sexual interest, and it's just not true. We just may need more support in order to learn how to make that happen. We don't naturally understand the nuances that are involved in this, and there are a lot of nuances.
There's a huge thing where people think that people on the spectrum, that they all don't have relationships, and if they do, that it doesn't even reach a sexual point. Having or not having those things does not determine whether one is on the spectrum or not.
Some of the ways that I show love that he might have thought were odd, he now understands that it's just my love language, my way of communicating, and in a sense, he kind of serves as my interpreter to the neurotypical world.
Often autistic people don't get taught sex ed at all, let alone how to protect themselves in the real world from date rape. These are topics that often aren't taught to autistic teenagers because adults don't want to deal with it.
People on the autism spectrum, especially women, are more likely to experience sexual assault or some sort of violent incident than the neurotypical non-autistic population. We are very vulnerable. We definitely can be more trusting because we are very honest and upfront people, so we don't think that other people might not be so honest and might be trying to hurt us.
One of the traits of autism is not reading between the lines in social interactions, and so much of dating and sexuality is supposed to be indirect and subtle, and that it's inappropriate to talk about sex in a direct way, even when you're teaching it as sex ed. Most of what they tested us on were the mechanics and can you label the diagram? No one's teaching the social aspects. And honestly, this is where autistic people are the canaries in the coal mine. Teaching the social aspects of sexuality would help everyone. Autistic people need it, but it also benefits everyone.
There's the stereotype that everyone with autism is into science and math and stuff, like Rain Man, but a lot of people with autism, women actually, especially, a lot of us are into the arts.
In my experience, autistic girls are also just as obsessive as autistic boys. They're just obsessed with, fantasy novels or their favorite bands or whatever, not, planes, trains, and automobiles.
Definitely. I'm more of a social science and literary person, and I've met a lot of other people on the spectrum who are into languages or music or art, and I think we thrive in some of those non-traditional areas.
I just sang at Carnegie Hall. I'm a writer.
I definitely started off with the interests of astronomy, and I actually ended up being one of the Mars One finalists, but it tends to be a stereotype, and I did fall into that stereotype.
When I was younger and I had no outlet, nobody wanted to hear from me, and I felt that I couldn't be myself, so I turned to writing.
People picked on me for any number of things, and I didn't know why. I didn't know what it was that they saw that was different. Nobody would ever tell me that. It's like somebody making fun of a blind person, only in this case, you're blind socially.
I felt broken. I felt strange. I felt different. Everything was so simple for other people. Everything they understood so easily that I couldn't understand, that I couldn't grasp or do. I just didn't understand what was so wrong with me.
The travails and difficulties I experienced with bullying and with being suicidal from a very young age. And I would say that we all start from somewhere, but that isn't necessarily where we're going to end up. And you have to believe that there is going to be a future. I didn't have that belief at that point. I didn't know that I was even going to have a future.
It's very difficult to go through many, many years, especially as a child, having no friends and no one willing to extend a hand out of friendship to you.
As I got older, like there were like high school, college, afterwards, there's enough misfits in the world, like people who got picked on. There's so many of us. So you do find your tribe.
To finally have friends is such a big deal.
I think if that 10-year-old girl could see what her life was going to be now, she wouldn't believe it. She would think it was some fairy tale or something out of a movie. I can't believe it because it almost seems like a dream at times that I've gotten to where I am, that I have a master's degree, that I've started my own business. And I also can believe it because I worked for it. And so I'm willing to give myself the credit that I think I deserve, which has always been something I've also struggled with.
I wished I could go back to that little Morenike and give her a hug and let her know that she was just fine the way she was and that she was going to be all right.
I think things are going to be a lot better for the next generation. Like, I'm actually really hopeful. They are going to be diagnosing children more, and there is going to be more social acceptance.
Your kid might be behind their peers, but it doesn't mean they're going to be behind forever. Your kid is a full human being who will grow and change just like everyone else.
I would just love to see every autistic person living up to their fullest potential, whatever that is for them. Success is about your child growing up to be the best version of themselves that they can be, whoever and whatever that is.
All right, so as you saw right there in that video, being on the autism spectrum, it has a variety of different outcomes for people with different kinds of problems. But that doesn't mean that somebody on the autism spectrum can't achieve, happiness, success in their life. And so there's a lot of support that's needed. There's a lot of help that's needed, a lot of education that's needed. But it's important to just destigmatize neurodiversity. And so right there in that video, you saw a lot of the differences, a lot of the problems inherent in the way we think about autism. So some of the individuals in that video told us about how a lot of these symptoms, a lot of these behaviors, a lot of these screenings were calibrated on young boys, not young girls. And so there's a lot of individuals who might slip through the cracks. And there's a lot of other differences that are coming up nowadays where we might want to think about refining and retuning and recalibrating our instruments to detect individuals earlier, and individuals from a variety of backgrounds and a variety of identities. And so if you're listening to this information and you feel like this information is out of date and needs to be updated, and you're really passionate about helping individuals who are on the autism spectrum, I would encourage you to join an autism lab, do some more research, do some reading, go to the DSM-5, send me an email, connect to resources. And definitely there's help out there for individuals with autism, for people on the autism spectrum. And also there's more learning that needs to be done. There's more growth required. So I would encourage you to, join the field. If you're interested in this stuff, if you feel like there's information that's missing, if you feel like there's more help that's needed, join in. All right, so right over here, we have autism spectrum disorder epidemiology. Let's talk about twin concordance rate. Everybody knows how much I love twin studies. So right over here, we see that the monozygotic twins, the concordance rates between 36 and 95%, and dizygotic twins, concordance rates between 0 and 31%. So what does this mean for us? Well, we can tell right here that there is a lot of variability. And because of the variability, we're not too sure exactly, what's going on here in terms of environment versus genetics. But as you can tell right here, there seems to be a higher concordance rate across the board, depending on which study you look at, for monozygotic twins as compared to dizygotic twins. And what we know with that, monozygotic twins share 100% genetic overlap. Dizygotic twins, 50% genetic overlap. So there does seem to be some kind of genetic link there. And so here's some examples of the genetic factors we have. So we have inherited genes versus de novo mutations. So inherited genes, those are genes that are passed down from your parents. And de novo mutations, these are genetic genes that are the gene expressions that occur for the first time in a family in an individual. So for example, if I am on the autism spectrum and then I have these certain genes that have been expressed for the first time in my family's history, that would be a de novo mutation. So there's 83% comorbidity with other genetic or neurological conditions. So what this means, you're thinking about Down syndrome, Fragile X, any other kinds of maybe some of the issues with like tuberous sclerosis, epilepsy, agenesis of the corpus callosum, these kind of things. There's an 83% comorbidity rate between autism and these other genetic issues. So there's actually a big debate on whether or not autism spectrum. Actually, there's a big debate all over the autism spectrum disorder about a lot of different things, but whether or not autism spectrum disorder should be considered a psychopathological disorder, or whether it's a normal genetic mutation, and this is just like a range, So for example, you have tall people, you have short people, but you don't look at short people and say, oh man, this person has like some kind of issue. No, there's a range of heights. You can be 7 foot tall, you can be 3 foot tall. There's a range of heights. That's just an example. Don't quote me on that and get mad because you got upset that I said that. But that's just like what we have right here. So some people are really wondering, like, should we treat autism spectrum disorder as psychopathology? All right, so right over here's some review for you. So which is true regarding who is most likely to experience autism spectrum disorder symptoms? A, children, as most adults can hide their symptoms. B, females, who often suffer to convey their impairment. C, children from low socioeconomic status families. Or D, individuals with Down syndrome. All right. The answer is D, individuals with Down syndrome. Why is that? Remember, we were talking about on the slide before, that there's an 83% comorbidity between certain genetic disorders and autism spectrum disorders. So Down syndrome is one of the disorders that I listed. So if you have Down syndrome, the chances of you expressing or presenting autism spectrum disorder symptoms is increased. All right, so now let's talk a little bit about autism spectrum disorder risk factors. It's not vaccines. So still to this day, the 1998 Wakefield study on the MMR vaccine is still cited in anti-vaxxer chats and message rooms. And maybe you're an anti-vaxxer. Maybe your parents are anti-vaxxers. I don't know. I don't care. But vaccines don't cause autism. They do not cause autism. And let me tell you why vaccines don't cause autism, because we'll talk about this 1998 Wakefield study. So there was an N of 12. So what does that mean? That means that only 12 participants were in the study. So of the hundreds of millions of people that receive vaccines, this study took the results and associations from 12 individuals and then said that generalized to hundreds of millions of people. Now, that's not really how science works. There's also no study control design. Also, there was faulty analyses. Also, data was faked. And there was a whole lot of issues when it comes to funding. There was a whole lot of issues when it came to the selection of participants. Were they randomized? Were they cherry picked? So this was one study. Now here's the thing. People took off with it. People ran away with it. People took the results from the study. Certain celebrities that shall remain nameless, they hopped in and they said, "Hey, yeah, vaccines cause autism, yada 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 yada." So here's one of the problems with the vaccines cause autism thing. So remember, correlation is not causation. So all children, for the most part, that can receive vaccines. So therefore, a lot of children with autism are going to receive vaccines. And also, when are vaccines usually due by? You want to make sure you get all the vaccines taken care of before the child goes to school, right? So before you go to school, you have your immunization record, right? Oh yeah, there's all different immunizations that I got, right? That's what you do before you go to school. You get your immunizations done, right? You present it to the district. You're like, okay, you can attend kindergarten now because you have your immunizations done. When do the symptoms of autism usually get detected? When individuals start going to school. Because now you're in the class with other individuals of the same age, and some of the differences, some of the social demands, some of the other dysfunctions, they are present. They are exaggerated. They are pronounced when you go to school. So now you might have somebody who's like, "Oh, I just got all the vaccines done for my kid, and then the teacher just said they have autism. Vaccine? No. That's not how it works. It's not how it works. All right? That's like saying, oh man, every time it's summertime and it's hot in the city and like people start shooting each other, and also in the summertime when it's hot in the city, people eating ice cream. So ice cream causes murder. No, you can't do that. I'm not trying to make a joke here. I'm just like, still to this day, it's 2020, and people are still talking about vaccines causing autisms, and there's certain situations happening right now where vaccines are becoming more important, and people are still talking about this madness. So this Wakefield study was retracted in 2010. But here's the problem. 10 years ago, a decade ago, it was retracted. But let me ask you a question. Where do you think they published that retraction? You see what I'm talking about? So people still take this discredited study, which was poorly designed. Like, so you right now, you listening to this lecture, this was a poor, like you're sitting at home right now, listening to this lecture, right? You could have designed a better study than this guy did, all right? It was slapdash, haphazard. It was terrible. All right, so that's the end of my rant. So I want to let you know, vaccines don't cause autism. Okay, just so we're on this. So what are some risk factors for autism spectrum disorders? Well, older parents. So older male and female gametes seem to increase risks. So this is going to be the combined age of parents is going to be a risk as well. So for example, if you think about like large age gaps, that could be a problem as well. We have prenatal exposure to substances. So this could be certain medications, certain antidepressants, low birth weight, extreme premature birth. So you have somebody who's, born at 26 weeks, this could be a problem. And also oxygen deprivation during birth. These can all potentially increase the risk of having autism. Okay. So there's also some additional things we want to talk about when it comes to risk for autism spectrum disorders, not vaccines. Autism spectrum disorders are not caused by vaccines. I just want to put it out there. Listen, zoom in. Listen, okay, I get it. I understand. The websites, the blogs, the Twitter accounts, the Facebook. I get it. Yeah, I understand. But it's important to know that vaccines don't cause autism. It's okay. I know it's hard. No, listen, no, it's fine. No, listen, no. I don't want to get into it. I'm sorry. I don't want to get into it, but I just want you to know that, just so we're on the same page, vaccines don't cause autism. Let's move right along. Why do we not believe that vaccines cause autism spectrum disorder? Okay, A, because doctors think the benefits of vaccines outweigh small risks of autism spectrum disorder, because there is some evidence that vaccines are linked to autism spectrum disorder, but way more evidence is that there's no connection, because the study linking vaccines to autism spectrum disorder suffered from a number of falsifications, because everything you find on the internet is true. All right, there we go. Let's take a look right here. Blah, 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 blah. A, B, C, D. Boom. The answer is C, because the study linking vaccines to autism spectrum disorder suffered from a number of falsifications, including just making up data. Listen, I'll make up data right now. I'll pull it out. I'll pull it out of a hat. I'll make up some data and publish it. And that's the ultimate, you know what? I don't even want to get into the discussions about privilege and stuff like that, but that's like the ultimate, like just to make stuff up and then people roll. If I made some stuff up right now and published it, never mind. That's outside the purview of this course. Let's keep on moving. Let's keep it pushing, kids. All right, so let's talk about the diagnosis of autism spectrum disorder. So how do you receive diagnosis? Well, autism spectrum disorder can reliably be diagnosed at age 2, but often it's not diagnosed until age 4. Why age 4? Why is 4 the magic number? Well, usually around age 4, kids start going to preschool, kids start, enrolling in kindergarten. And so now it's like, oh, okay, cool. Yeah, this is nice. So early intervention leads to better treatment response. So why do we diagnose early? Well, you don't want to scare parents, but you do want to kind of give them a heads up. You do want them to be on the lookout for autism spectrum disorder. So this is really good to help an individual get diagnosed early. That way, when they go to school, you can say, hey, guess what? My child has autism spectrum disorder. The school district, which should be receiving funding, and I'm not going to talk about how we fund our public schools in America, and that's outside the purview of this course, but there should be funds available for support so that every individual who is in school can receive the same level of care and access and opportunity to education. And so if you have an autism spectrum disorder diagnosis, now you can receive the help and care that you need in order to meet your educational goals, to make sure that you can have a good life. All right. So during pediatrician screenings, there's different kinds of developmental screenings that are done. You might remember some of these. The pediatrician asks you a bunch of questions, it's tapping all over your body, just seeing what's going on. A lot of that's just normal checkups, but also if your parents suspect or a caregiver suspects that you might have autism, they can ask these questions to try to figure things out. So here's a list of some of the questions right here. So we have the modified checklist for autism and toddlers, MCHAT-R, and in other kinds of screenings that pediatricians can conduct to make sure that your child is or that a child is hitting on the developmental milestones that they need to, but also maybe detect anything else that's going on. So remember we talked about earlier, this is usually detected in a preschool, kindergarten, a school setting. Then you might, report some of these problems to your pediatrician. Your pediatrician might do a screening and then refer you out to somebody else. And actually here on campus, we do autism screenings through our program, but also, through the Counseling Center, McKinley, things like that. And so at the Psychological Services Center, the PSC, we actually do autism services, or autism screenings as one of the practicums for the clinical community students. And at the current time of this lecture being recorded, December 2020, Amy Cohen is in charge of that. All right, so right over here, this is the ADOS 2. So this is what we use at the Psychological Services Center, among other tools as well, to help screen or diagnose individuals with autism. So here is going to be, I'm going to leave this up here for you. You can take a look at it. You can read through it. It's in your slides as well. So this is the gold standard of screening, is a combination between the ADOS and the ADI. When you combine these two together, usually you get a pretty good, it's really good fidelity, right? So you can really tell, or you can really, narrow down what's going on within the individual and make a good, clean diagnosis. So you really don't know the specifics of all this, but you do want to know the abbreviations and the basic idea of the both. Now, on top of all of this, you want to have multiple accounts and multiple clinical observations of the individual with autism to try to figure out what's really going on, because some of this stuff that we get in the sessions isn't sufficient enough. So like I said before, we have a lot of self-report measures where you have a lot of lived experiences, what's happening in school, what's happening at home, what's happening with friends, and this can definitely help out. So take a look right here, what we have for you. Woo! There we go. And you have the slides. If you have any questions about how this is done, there are videos available to look at this, or you can send me an email. We can talk more about it. All right, so let's take a look right here, some review for you. So, which is not a way we diagnose autism spectrum disorder? A, through observing the individual. B, through gathering information from multiple sources, including the parents. C, through IQ tests. Or D, through developmental questionnaires. This should be easy. Sip, sip, sip. Through IQ tests, we do not conduct IQ tests for autism. Now remember, even though I said before that 50% of children diagnosed with autism have below average IQs, that's not enough. So like that would negate, or that would leave out 44% of children. So we do not do IQ tests to diagnose for autism. Now, once someone has been diagnosed with autism, you might do an IQ test. Of course, IQ tests are problematic. Please don't cancel me on Twitter. I know, but you might get some kind of idea of educational attainment or any kind of educational difficulties created by the autism, or maybe because of the autism, or because of the issues associated with autism, there's some problems in school. Maybe you can make some modifications. Maybe you can make some, some accommodations to support the child. But we do not use IQ tests to diagnose autism. Okay, there we go. All right, so let's talk a little bit about neurodiversity. So neurodiversity is a belief that the natural range of behavioral, emotional, and neurological functioning that is found in nature does not need to be corrected. So this was actually started in the late 1990s, and it was popularized by a book called Neurotribes. Now, this is actually hotly debated, particularly in the autism spectrum community. We'll talk about a little bit about this in the next couple of slides. But individuals who believe in neurodiversity, or in the neurodiversity movement, believe that, hey, there's nothing wrong with having autism, and this isn't something that needs to be cured. This is just a spectrum, a range of behaviors that is natural. Now, as we talked about earlier in class, we know there were some other things that were once considered psychological disorders, but now we accept that these things are naturally occurring and there's nothing wrong with it, and it doesn't need to be corrected. If you've been paying attention in class, you know exactly what I'm talking about. If you just joined us, you're probably like, oh, what are you talking about, Walter? What are you talking about? But you know what I'm saying? So this is hotly debated in the autism community. Some individuals believe that, hey, I have this problem. I want to be normal. I want to be fixed. Some people are like, my child is nonverbal. My child has all these issues. I want my child to be fixed. Other people say, get your hands off my baby. My kid is okay the way that they are. They don't need to change at all. All right. So we're going to talk about on the next slide when we talk about a little bit of these, some of these stories, some of these testimonials. But it's important to understand that neurodiversity, the movement, is controversial within people within, or I should say, it is controversial for people within the autism spectrum disorder community. Okay, so there we go. And you can look at these books, you can look at these stories, send me an email, come to office hours, we'll talk about it. All right, so right over here, we have two competing views. So many individuals who embrace the concept of neurodiversity believe that people with differences do not need to be cured, they need help and accommodation instead. So this is somebody who believes in neurodiversity. They're a supporter of the neurodiversity movement. Here's a different story. I have two kids with nonverbal autism. It's an extremely severe neurodevelopmental disability. They can't talk, they can't read, they can't write, they can't add 1 + 1, and they lack any capacity for abstract thought. Neurodiversity advocates trivialize this and cherry pick naive, feel-good stories that portray autism falsely instead of grappling with its reality. So these are some very different views, right? And so who's right? Who's wrong? I'm not going to tell you who's right and who's wrong. You've got to decide that for yourself. I mean, can both these be right? So is it a possibility that we should accept, that neurodiversity is a thing? And also, we should think about how to help individuals who are suffering or who have disadvantages, right? Can these both exist at the same time? Are these diametrically opposed viewpoints? Can they coexist? I don't like these polar opposite things. I don't like these things where it's like you're on this end and you're on this end and you have to choose a side. You're on this side or you're on that side. That, for me, I don't like that. But I want to know what's in between. That's the way I think about things. What's in between? What's going on here? What's happening? It's like there's this side, there's that side, right? What's happening in the middle, right? Like, we're not supposed to like binaries. So let's get rid of this binary thinking. Can we say that maybe some people, from my personal opinion, I feel like what the second narrative is saying fits within the first one. Because this individual's talking about, hey, they need help and accommodation. This person needs help and accommodation too. What's the difference? Maybe I'm wrong. Maybe I'm naive. Maybe I'm cherry picking my examples. I don't know. What do you think? Send me an email. Talk about it. Come to office hours. Let's talk about it. Let's have a conversation, right? And I'm not the authority on autism. Just because I say something doesn't mean it's right. That's how I feel. So maybe I'm wrong. Maybe I'm missing something. Maybe you know something I don't. Let's have a conversation, everybody. There we go. So let's talk about treatment for autism spectrum disorders. Let's get into a little bit of applied behavior analysis, ABA. So this is a treatment that uses positive reinforcement to increase desired behaviors and ignore problematic behaviors. So what you want to do, you want to identify the antecedent, whatever, what comes before the behavior, what comes afterwards, the A, B, C. All right, people love this stuff. All right, so this is actually the most popular treatment right now for autism spectrum disorders, but it is highly controversial. Let's go over why it's so controversial. It's controversial because the pros and cons make you pause. So the pros, this can be done in any environment. This often includes a one-on-one aid. So what that means is I don't have to go to the clinician's office to do ABA. I can go to your house. We can do it online. We can do it at school. We can do it in a variety of different locations, right? So this one-on-one aid, this means that like I'm working with you directly. Like I'm your ABA specialist, and I'm helping you out, and I'm helping you achieve the outcomes that you need. And there are results. So we have increased eye contact, we have decreased stimming behavior, we have better outcomes in educational attainment and professional attainment. So ABA has been shown to work. The problem is it's very expensive because the insurance company will recover so much. There can be harsh treatment of the child depending on the provider. I know some of you are thinking, oh, Walter, no. But what I'm saying is depending on the provider, you might receive harsh treatment. And usually this is practiced by young postgrads with lots of turnover. Now, Walter, why would you say that? Well, remember we were talking about, for those who went to the extra credit grad panel, we're talking about PsyDs and PhDs and the differences. So ABA is a master's level program where within 12 to 18 months, you can become a certified applied behavioral analysis. Some of these programs can be for profit. So you kind of question the educational attainment achieved during those programs, the expertise attained during those programs because of the high turnover. Like for example, if you go to a clinician's office, right? Chances are in 20 years, that same clinician will probably still be practicing. With ABA, it's a little bit different. Maybe people go back to PhD school, maybe people do something else. The demands of the job, the pay might not be commensurate with the effort that was put in. There's a lot of turnover. There's a lot of reasons why this might happen. But usually, you want somebody with a lot of to gain experience over time, right? So like we all know that when you first graduate from something, you're going to be a young postgrad. But hopefully, eventually, you'll be 10, 20, 30 years in the game, right? And you'll know what you're doing. With ABA, there's a lot of turnover, so a lot of the people that you're seeing don't have a lot of expertise or experience, and you might make an argument it could be better to go somewhere else. Also, autism spectrum disorder individuals and the advocates of the neurodiversity movement say that it focuses on changes that are only important for neurotypical people. So what this means is, the things that we're focusing on changing in ABA are to try to get these neurodiverse individuals to act more like neurotypical individuals. And so that's one of the problems with that's one of the issues that people in the neurodiversity movement bring up, is that, neurodiversity is a thing. We should accept diverse behaviors. We should accept diverse individuals, and trying to make everybody neurotypical is problematic. What do you think? Am I right? Am I wrong? I didn't really take a stance there, but you tell me what you think. Come to office hours, send me an email, do some research on your own. What's right? What's wrong? Who knows? It's a gray area. So here are some other treatments that we have. We have behavioral management therapy, joint attention therapy, social skills training, and then the Early Start Denver model. We're going to get into each of these a little bit, but if you feel like you want to know more about these, send me an email, come to office hours, let's talk about them, but I'll have more information in the slides coming up. So behavioral management therapy, so this is where you want to identify positive behaviors, which are going to be desired, and then you want to identify negative behaviors, which are unwanted. So you want to identify desired and unwanted behaviors. You want to reinforce the desired behaviors and extinguish or ignore the unwanted behaviors. And then you want to have other people in the individual's life model but desired behaviors. So this is something that reminds you of child rearing, right? You want to reward the child for doing something right. You want to try to ignore or extinguish unwanted behavior. So for example, if a child hits their toe, and they're crying out loud, you might want to comfort them and help them out, right? But what you don't want to do is get into a point where, every time the child is crying or outbursting, that you're like, jumping on, hey, what's going on? Yeah. You kind of want to say, okay, hey, you hurt your toe. Let's take a look at it. Oh, your toe looks okay. Your toe looks fine. Don't worry about it. There we go. Let's do something instead. Let's check on it. Let's look at the toe. Oh, look, it's not bleeding. Oh, look, there's no bruise. Don't worry. This hurts. I know, but you'll be fine. It's okay. Something like that. That's for like when you're raising a child, right? But so with this right here, you might have somebody who has different kind of outbursts, different kind of behaviors. You might want to reinforce desired behaviors such as, oh, hey, you did a good job here. You self-soothed yourself. Everything's okay, rather than the outbursts and things like that. And then you might want to model the desired behaviors. So this is how I would respond to it. This is how we should respond to it. Let's do that together. You have joint attention therapy. So this is going to be focus on the ability to communicate shared attention, usually through pointing, showing, or coordinating eye gaze. So you want to try to get their attention, point to something, look at it together, maybe play with a toy together. And this is going to reinforce engagement, and it's going to increase different kinds of outcomes over time in terms of being able to hold eye contact with other people, to share play, to share ideas, to share attention with other individuals. We have social skills training. So just like it says right here, you want to help individuals rehearse different kinds of social interactions. There's like friends, at the job, in class, relationships, all sorts of kinds of social situations. You want to model how you should behave. You want to reinforce positive behaviors. You want to help an individual achieve those social attainment goals. Being social is very important. So you kind of want to try to help individuals navigate through life. And then we have the Early Start Denver model. So this is for people between 1 and 4 years old. This is a very early intervention. This is based on applied behavioral analysis. It's going to be in play settings, and this is going to include naturalistic settings. So like putting a toy just out of reach, or, holding onto a toy tightly. So you want to make sure that like you're trying to increase, or you're trying to encourage the child to play, to explore, to be more social. All right, so right over here we have some more review for you. So which autism spectrum disorder treatment is considered the most controversial? We have A, ABA, B, behavioral management, C, joint attention, D, social skills training, E, Early Start Denver model. What's the answer to that? Boom! A, applied behavioral analysis, for the reason we talked about before. High turnover might be distressing to the child. You're kind of questioning, the rigor, the academic rigor involved with the education itself. Maybe worry about the expertise. And also, people who support the neurodiversity movement might believe or might feel strongly that ABA is trying to make neurodiverse individuals neurotypical. All right, so here's some review right here. So individuals without autism spectrum disorders or other neurodevelopmental or psychopathological disorders are often called A, normies, B, neurotypicals, C, neurocontrols, D, neurostandards. What's the answer? B, neurotypicals. All right. So remember, we have neurodiversity, neurotypical. So now let's talk a little bit about treatments for autism spectrum disorder. I should say continue our discussion on treatments, focusing on medications. So we have ADHD medications. So ADHD often co-occurs with autism spectrum disorders. So by taking ADHD medications, this can help with planning and focus. We also have anti-anxiety medications. This can actually help with rigid and repetitive behaviors, some of the outbursts, and also anxiety disorders often co-occur with autism spectrum disorders. Antidepressants, this can help also with the disappointment and the anger and the the feeling of being ostracized or alone with these repetitive or rigid behaviors, and this also can co-occur with autism spectrum disorders. We have antipsychotic medications, so this can help with irritability, impulsivity, and other kinds of meltdowns. And then we have sleep aids, so melatonin is good, and other kinds of over-the-counter medications might be good, and this can help towards the end of the night, getting to sleep. Actually, you know what? I take sleep gummies as well. Melatonin is a good thing. I would recommend it to anybody. It's not an official recommendation of any brand, and I don't have any stock or anything like that in any of these companies, but it's changed my life. So atypical antipsychotic medications, these do help, but they should be used with care because they typically have especially difficult side effects. So this is not something you're just going to like haphazardly prescribe to somebody. You want to make sure that this is only in severe cases and the costs or the benefits outweigh the costs. All right, so right here, we're now going to move on to attention deficit hyperactivity disorder. So we're going to talk about patterns, well, I should say we're going to talk about the symptoms of inattention and hyperactivity. First we'll do inattention, then we'll do hyperactivity. So this is going to be a persistent pattern of inattention or hyperactivity that interferes with functioning in 2 or more settings. So that means home, work, school, etc. So inattention is going to be 6 or more of the following symptoms. You need to have often fails to give close attention to details, often has difficulty sustaining attention, often does not seem to listen when spoken to, often does not follow through with instructions, having difficulty organizing, avoiding, disliking, or reluctant to engage in sustained mental effort, loses things necessary for tasks, being easily distracted, often forgetful. And so for this right here, you need to make sure that you have a duration for at least 6 months, and at least some of the symptoms have to be present prior to age of 12. So in the DSM-5, we have these diagnostic criteria. I want you to go there, look it up, read them. All the information is on the slide. I don't feel like reading the slide off for you. What can I say? So to go ahead and read off the slides, this is what you need. All right, just remember you need 6 or more of the following. All right, they have to be present for these 6 months. Some of these have to be present prior to the age of 12. All right, so now we have hyperactivity and impulsivity. So you need 6 or more of the following. So you have fidgeting, you have getting out of your seat in inappropriate situations. You might have climbing things or running about. You might have unable to chill out or engage in leisurely activities quietly. You might also have somebody who's always on the go, always driven by a motor. You have somebody who might be who talks excessively, someone who blurts out an answer before a question's been completed, somebody who has difficulty waiting their turn, somebody who often interrupts other people pretty quickly. So once again, this is going to be for at least 6 months, and at least some of these symptoms have to be present prior to the age of 12. Now, there are going to be some specifiers. You're going to have mild, moderate, and severe specifiers for ADHD, and that, of course, depends on the number of symptoms and the number of dysfunction and impairment present in the individual. This is going to be on a case-by-case basis, so you're going to need to do some work with the client to figure out what's going on. Also, go to the DSM-5 chapter. There's more information on that in the DSM-5 chapter because reading is fundamental. Also, there are some specifiers in regards to inattentive type, hyperactive impulsive type, or joint presentation. So you can have, the hyperactivity impulsivity, you can have the inattention, or you can have both. So there's more information in the DSM-5 about that. Please read the DSM-5 chapter. It's very informative. All right, so here's some review here for you. So Justin's parents report that since he was little, he gets easily distracted by things like rays of light, floating specks of dust, or background noises. Because of this, he has difficulty following through in activities and cannot follow their directions or listen when they speak directly to him. Justin's parents say that he talks excessively and will often just run around. So based on this information, which Justin would likely receive a diagnosis of what? So we have A, attention deficit hyperactivity, inattentive, attention deficit hyperactivity disorder, hyperactivity impulsive type, ADHD joint type. Okay, or D, no diagnosis. Alrighty, what do you think? Alright, what do you think? Answer is going to be D, no diagnosis. So remember, how many symptoms did you need? Let's count the symptoms. Okay, easily distracted. That's 1. Let's see. Following through with activities. Following instructions. Okay. Let's see. Talking excessively. Running around. How many symptoms do I need? I need 5. Okay. So, there we go. Now remember, you got to meet the minimum number of symptoms to meet criteria. Do not let me fool you. Do not let me fool you. Okay? All right. So let's talk about some epidemiology. So right over here, about 9.5% of population meet criteria. So males do get diagnosed more than females. This could be a true gender difference, or males might be more likely to show hyperactivity and impulsivity with or without inattention. Females might be more likely to show inattention. There could be socialization factors in effect here, and externalizing behaviors are more likely to receive attention and therefore receive a diagnosis. So it could be that males and females equally have ADHD. However, due to socialization and other factors, males get the attention first and females might get the attention later. It just depends. All right, so 60% of children with ADHD also have comorbid diagnoses. So, for example, 83% of children with ADHD have a comorbid behavioral or conduct diagnosis, and 50% of individuals with ADHD would have comorbid anxiety disorders. So children on Medicaid, which is the government-supported health care, are twice as likely to receive ADHD diagnosis than children on private insurance. And less than 50% of children on Medicaid are likely to report receiving services. So what does this mean? Well, this shows us that on those on government health insurance, right, or like government-supported health insurance, they're going to receive a diagnosis. However, they're not going to receive the same level of treatment and care as those with private insurance. So what that means is you might not receive the kind of therapy that you need, the medication that you need, other kind of supports that you need. So this shows a little bit of a socioeconomic divide in the treatment of ADHD. Sorry, I almost said autism there. Well, I guess I can make a case that you have a socioeconomic divide between autism spectrum disorders and ADHD. So never mind, I'm not going to correct myself. All right, so all of the following except blank could it could influence your likelihood of receiving an ADHD diagnosis. A, gender. B, which type of symptoms you present with. C, spoken language ability. D, parents' income. Let's take a look. So yeah, your spoken language ability. So once again, your spoken language ability, this is not going to be one of the factors that might influence the likelihood of receiving a diagnosis. But definitely those other three would be factors that could interfere. Remember, with our symptoms of autism, we might look at something like spoken language ability, but when we're talking about ADHD, a little bit different. So spoken language ability might not be something that someone would cue someone to think about ADHD. All right, talk about the treatments. All right, so we have mostly stimulants being prescribed for ADHD. So we have methylphenidate. So this is like Ritalin, Concerta, Daytrana, Focalin. We have amphetamines, Adderall, Dexedrine, Vyvanse. So both of these types of medications increase dopamine and norepinephrine activity by preventing their reuptake. So these drugs, by allowing greater dopaminergic and norepinephrine functioning, thereby affect cognition and executive functioning. They also improve risky decision making. They improve emotional responsivity, and they also improve the regulation of reward processing. So methylphenidate is thought to be slightly more effective, but it really depends on the individual and like the differences of the individual and their preferences. The problem is we worry about abuse of these medications. Now, I know no one at home listening to this lecture has ever abused Adderall or taken an Adderall, or you've never heard of people popping Addies to have fun. But that it's a thing where some people will recreationally take Adderall, to get high. Not just to like have all-night study sessions and pass their finals, but they will pop a couple of Addies, go and have a good time. Okay, if this is the first time you're hearing this, don't do drugs. Look at me. Don't do drugs. I'm not advocating for drug usage. I'm saying that people do use drugs. That's all I'm saying. Okay. All right, don't cancel me on Twitter. Just chill out. And there are other side effects as well. So, for example, there's some health issues. So, these kinds of stimulants can cause high blood pressure and other kinds of cardiovascular problems, which can lead to, stroke, heart attack, other kinds of issues later in life. All right, so don't abuse drugs either. That's a bad idea. So, when it comes to therapy, these are also some treatment options that we have for ADHD. So, you have parent training. So, by training the parents, this could help the parents to help with assisting in planning, reward positive behaviors, help the parents with giving warnings, help the parents with adjusting expectations. So what happens a lot of times is you have parents who become exasperated. They're doing a lot of different things. They're trying to work. They're trying to take care of a household. Now they have this child who needs support and need of care. The parents might not have the resources, the education, the planning to understand how to help this child. So by training the parents, they can help the child, they can help themselves, they can readjust their expectations, and they can really achieve some good outcomes. You have behavioral management in school settings, so you can have a special plan with the teacher, an educational plan where the child might have more movement, keep things organized, maybe like focus more on tasks, reduce distractions. Some school districts refer to this as a 504 or an IEP. This can also give individuals more time on tests. If you're familiar with DRES, here at the university, DRES is also a way that individuals can receive support here in the university for ADHD and other disorders, and this can be helpful. Also, you have social skills training. So a child with ADHD might have problems with friends, might have problems with playing, might have problems with things to do, like with behaving in public. So through social skills training, you can try to help the individual to understand appropriate behaviors. There's also environmental changes that you can do for the individual with ADHD. You can do pedal bikes, you can do fidget toys, and you can do other kinds of sensory corners to try to help the child or the individual to expend any kind of excess energy they might have or refocus them. So fidget spinners were really popular a couple of years ago, and some people still use them, but now you have a lot of these really clicky things you might do, and that can really help you out. All right, so let's look at some more stats on ADHD treatment. So let's look at 2016. We have some data here about child treatments. These are for children between the ages of 2 and 17. So 62% of the children take medication and 47% receive therapy. About 30% of the children only use medication. About 15% only use therapy. 32% use both medication and therapy, and 23% receive no treatment. There's some other stats here for you to take a look at. You can pause the video, look at your slides. Let's keep it moving. So right over here, we have some information about ADHD in adults. So about 50 to 80% of symptoms continue into adulthood. And then physical symptoms might become easier to hide around adolescence. So later diagnosis usually includes higher functioning, but cases might vary. The diagnosis is still going to be based on childhood symptoms. One of the problems with diagnosing people in adulthood is worry about malingering. What is malingering? Malingering is when you pretend or you fabricate symptoms in order to achieve a diagnosis. This is because medication is often desired later in life. So, for example, there's this movie and a show called Limitless where this guy takes a pill and he feels like he's on $1 million. Some people have described Adderall as being like that. I'm not trying to, you know what I'm saying. So there's a concern that someone might try to get a prescription for Adderall and abuse it. So medication might be withheld or substituted for something else. So, for example, ADHD might be treated in adults with antidepressants, or you might just focus on more therapeutic techniques like vocational counseling, or even like for me, I use this app called Evernote, which helps me out. And so there's a lot of different kinds of resources and tools available for individuals or adults with ADHD to get things done. All right, so right here, we're going to watch a video. This is about adults with ADHD. I'm going to jump out the way. I'm going to let you watch this video, and then we'll get back and we'll talk about it.
Life at home was very difficult. I was quite a stubborn child. I was often quite a recluse, and that could be on the flip side that I was hyperactive, wouldn't accept things, wouldn't listen. All of the classic things really that you'd associate with that, and therefore home life, meal times especially, things like that were difficult. It sort of carried over into school as well. It was always the classic thing, he's got potential, he's obviously got brains but never applies it. Back then I could be very strange, I could be a recluse, strange. Obviously the impulsivity brought things out that you don't want to say or do. Really badly behaved.
One of my teachers said, you know, to my mum, you know, Bev's a wonderful girl, she's a great person, but she won't amount to anything. And that is a really, really sad thing, because it stuck with me. And at 34 years old, I'm trying to get rid of that. And I find that incredibly difficult still, to this day.
Constantly sent out of class. I'd stayed in a class about 5 minutes, something like that, and I'd get let back in. I'd get let back in quite often because it wasn't bad stuff, it was just making a joke, which was probably inappropriate to stop the teacher from teaching.
So I went to see the headmaster and did try to get something from him, saying, look, you know, there's something. I'd always felt there was something as his mother, but I didn't quite know why, and that was why we chose that school, because it was a bit smaller. But they would refuse. They said we don't want to label children at this age, and I said, give me a label. I said, and then we can deal with it.
I was glad when school was over, definitely. It was a miserable time. Because I didn't fit in a dynamic of girlfriends, I started to hang around with men and sort of got sexual very early in age. I was 14 when I lost my virginity, and it wasn't to somebody of my own age, it was someone a lot older. I took massive risks. I was lucky that I didn't end up being stabbed or raped or anything like that, because I would take every risk possible.
I was very emotionally sensitive as a child. But I didn't seem to have that hard shell. Everything got to me too much, if that makes any sense. And part of the problem with that, I found as well, is that I probably came across as, I don't know, too needy or clingy, or, you know, when someone, you know, an acquaintance, friend, peer would pay me any attention, it'd be like, you know, I'd be in there, yeah, all right, you know, best buddies for the, you know, whenever they're just, whoa, back off, dude. You know.
I applied and went to uni. I mean, pretty much from the first day I was there, I was never going to be able to even start interacting with a university degree. I just didn't know how to plan, no forward thinking, you know, got sucked into the whole social scene. But I mean, certainly that was a secondary issue. That was just, instead of confronting what was going on, really. In the first term I was there, or second term, I became a complete recluse because I didn't know, you know, I was lost really. It was like just sort of going through limbo. It was time for me to accept that there was something that needed to change. And I think I was subconsciously desperate for an explanation.
I got some GCSEs, I got 2 A levels, I went to university, and I pulled out halfway through my course. I couldn't concentrate on the academic kind of stuff. It was boring.
Books, they're not on the agenda, they never have been. Watching films, I can't watch a film in silence. Like, I can watch it on my own in silence because I can do stuff on my phone or something like that while I'm watching it. But if someone else is there, you know, I'll make comments on the film as I go along. I'm not one of those people who just sit there and go like that.
Doing household chores, I'll bring washing down and I'll think, right, I've got to put that in the washing machine. So I'll put it next to the washing machine, and then next to the washing machine is the dishwasher. So I'll start undoing the dishwasher, start putting stuff in the drawers and cupboards for the dishwasher. Then I'll go, oh, I'll look for some parts for the dishwasher. Then I'll go into the front room, start looking for parts. Then I'll start tidying up in there. And basically nothing ever gets properly done.
Say, for example, I'm sitting down and I want to work on the computer. It was almost like, you know, okay, I've got the screen in front of me and I'm wanting to work on that. But I've got this, you know, all these thoughts and ideas and everything flowing. And I've got to fight through them just to get to what I'm wanting to work on. And it's certainly not that I don't have ideas or have thoughts or things like that. The problem is I have too many.
In terms of friendships these days, ADHD can affect certainly things that I say I'm going to do with, you know, events or gatherings or birthdays, and I clearly can't do them either when I've said I clearly can because of financial reasons or, you know, just time.
Ultimately, it can be incredibly frustrating. If you are in a relationship and you are disorganised and the person that you're with is very organised, I think that can cause a lot of tension, you know. And I remember my partner putting a load of bin bags by the front door, in front of the front door, to remind me to take them out, and apparently I stepped over them.
I think Joe struggles if I ask him to tidy his bedroom up and empty the dishwasher.
Why is that a struggle?
I don't know, see, I don't understand that, but then Joe will say, look, now you're asking me to do too much, and so and he'll actually then be sort of, well, not confrontational, but it'll just be difficult, and he'll say, I'm not going to do any of it for you now.
A common thing with ADHD is you just kind of have children young and have quite a few children and sort of stuff like that. School routine, disastrous, always late, never on time, never organised. My house was a tip, still is a mess, but it's a reasonable mess now, whereas it was like, you know, sort of, right, Zach's nappy's off, right, and I'll pick that up later and stuff like that.
It's more been frustrations over time than surprises. Things like going out, leaving the back door wide open but setting the alarm, going out, leaving the front door keys in the front door, not locking the car, never having any money on him, forgetting all sorts of things. Oh, it's limitless.
I've engaged more with services like those from the QMC. I've looked at my medication and changed the dosage a bit, and I've developed a few systems for myself, because I've been able to slow down and just have a look, particularly during the summer, about how I can do things differently.
It made me understand why I am the way I am. And it was like, you know, being told by a psychiatrist that you're not stupid and that you are all right. That was good. It was also sad at the same time, because if they could have found that when I was a little girl, I could have been achieving so much now. And I just think, you know, and part of me just thinks, you know, maybe I'm a bit of a letdown because I'm not doing what I want to do. And I desperately want to, but I don't know how to.
Without sounding cheesy, getting the diagnosis has changed my life as such, because now I've got the help. Obviously, I was not doing well at school, and then at college I came out and I was one of the best students.
I think at last for Joe it was a relief to know that there was something that was causing it.
I was so kind of relieved, and that I thought I was going a bit mad, and almost like a hypochondriac, because I knew there was stuff that was wrong with me, but kind of didn't know what. So everything that I was hearing around me, I was linking to and sort of going, well, that's like me, but you know, kept on being told, well, no, you can't, you're an adult, you grow out of ADHD. It's like having your glasses cleaned after them being steamed up. I just feel more awake. My friends have noticed that I'm more focused.
I certainly didn't feel great, you know, yeah, hey, I've got ADHD. I mean, I felt good because I had an idea of what the issue was, and knowing what the issue was, I also knew that there were, okay, now we can deal with it. Now we can figure something out. There are pharmacological aspects that can be dealt with. There are CBT aspects that can be taken into account. You know, we can develop strategies to deal with this. Great. But on the other side, okay, I've got ADHD. I've got a label, you know, and I felt this kind of self-imposed stigma attached to it.
I was aware of it, but to me it was always something kids had. You know, it was the child bouncing off the walls at school, and because the hyperactivity element was there. But Scott's never, since I've known him, he's always been the calm one, you know, he's never had that sort of bouncing off the wall type thing going on. So I think it very much surprised me. It's been some serious light bulb moments since the diagnosis. It's learning to accept that sometimes it's not the end of the world if the milk gets forgotten, and you can always take things into school if they get left behind and things like that.
At the moment, I'm obviously, like you said, doing football coaching. I've recently started doing it, running a certain franchise in the Nottingham area. I feel my ADHD helps me with that because obviously I can relate to the kids. They're more, you know, energetic rather than, you know, turning up a bit, you know, moaning I'm tired, you know. Once I'm up and it helps me with the kids. So I get involved and relate. I'm just like one of the kids.
I've been doing the job now for quite a few months. Can't remember how long. Initially, when I first started there, it was great because I could kind of, you know, do the important things in the morning and get that all out the way and kind of have a more sociable afternoon, as it were. But now my job role is about being totally switched on for the whole day. And it's an absolute nightmare.
What makes it difficult?
Looking at spreadsheets with numbers on. I mean, how boring is that?
I'm working from home. My wife works from home. There are a lot of great things about working from home. But everything here distracts me. Most people, when they turn around from something, they can answer whatever it is, and then they turn back and they go back to what they were doing. Whenever I turn away from whatever I'm doing and look back to it, I don't really know where I was.
So there are times when I've been able to, you know, come up with an idea or a concept that wouldn't have been possible for everyone else, but it would have taken them more time.
Being spontaneous, and I love that about me, and I think it's a great thing, and I think other people can feed off that, and they're like, yay, Bev's being spontaneous.
I'm a funny guy, you know what I mean? I make people laugh. Probably could do it for a living.
You have wacky ideas. You decide to go to drive all the way to Birmingham for a McDonald's, drive to Skegness for a pair of sunglasses.
I have energy like crazy. You know, I get out of bed in the morning, and you know, I think everyone has that initial sleepiness, but quite often it's very easy for me just to hit the ground running.
It has taken a long time still. I mean, there's still every single issue there, but they're just slowly sort of alleviating.
Rather than seeing it as, you know, a negative thing, or it's because you're thick, or because you're, you know, stupid, or because you're lazy, or because you just can't be arsed ever. You know, it's about, you know, making the best of what you have.
I'm not worried that I might have to take these for the rest of my life, because this is what's making me think more, and actually things that I thought I was incapable of, I'm very capable of doing.
It's getting better. I find that if I say I'm going to spend 15 minutes on something, then I can use that as a kind of a hyper-focus type and just move, boom, 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 and get it done.
For me, it's been a big learning curve, and it's taken me some time to get used to the whole idea, because this is for life. And we're getting there. We're getting there slowly, but we're getting there. Yeah.
All right, so there we go. We have this nice little video right there talking about adults with autism, their life, their lived experiences, some of the difficulties that they had, and then also some of the victories. So what do you think about that? What do you think about that video? What did you notice in there? What are some of the narratives that maybe you heard from the first time? How about maybe some false beliefs that you once held that were changed because of that video? Just think about it. You know, tell me what you think. Send me an email. Come to office hours. Let's talk about it. So here's some quick review right here. So adults with ADHD are more likely to A, outgrow their symptoms, B, be poorer functioning than children with ADHD, C, be assessed based on their current symptoms. D, be screened to ensure that they are not lying. All right, let's take a look right here. All right, the answer is D, to be screened to ensure that they are not lying. Now, this happens a lot, when, people think that, hey, you're trying to do the medication, trying to get like your hands on some Adderall or something like that. You're trying to, game the system. So people put a lot of barriers in place for adults with ADHD to get treatment. So right here, kind of similarly to the video we just saw about adults with ADHD, this video is about adults with autism. So, there's a lot of things that the media, popular culture has put out there as like popular portrayals of what autism is, of how autism, presents itself in adults. So this is going to be a different kinds of narrative with individuals talking about having autism as an adult. So what I'm going to do is I'm going to press play on this video. We're going to watch it together. And then when we get done, we'll talk about it.
I think I'm excited. I'm not sure what the future would hold, but I'm sure that something good will come out of that. My name is Brett Cathcart, and I'm 30 years old.
When we were told that there were some behavioral problems that he had and he might be autistic, I never felt that he was going to be someone that couldn't grow up and be on his own.
I'm a bagger. I bag groceries for customers. Sometimes I help take them out to the car. I was hoping they'd give me more stuff to do, like stock shelves, because you could get paid more. I wrote a letter to ask if they have any new positions open, but I didn't get any. It's a disappointment.
Autism is traditionally called a childhood developmental disorder, when actually it's a lifelong disorder. A person has the right to stay in the public school system until the age of 22. And then the instant the second hand crosses at 12 and at midnight on their 22nd birthday, the school system drops these folks like a hot stone. Very little is on the other side of that 22-year divide, what is sometimes referred to as the 22-year cliff. The rates of employment are anywhere from 20 to 50%. So in other words, 80% unemployment.
There's not the social services out there to help a child like this that people think they are. And without their strong family background and a financial wherewithal, I think a young adult has become lost in society.
So did you work really good this morning?
Yes, I did.
Okay, because Marianne will ask you.
What will we do with the tidal wave that is hitting the beach from the 1990s so-called autism epidemic? If we don't figure it out now, it's going to become a catastrophe, in my personal view. Hardly a week goes by that I don't hear from parents in the clinic, "Doctor, what happens when we get too old? I'm just not going to be able to meet his needs. Then what do we do?" And I don't have an answer for them. It's frightening.
When you're there watching them grow up and you know what they're capable of doing, and what they're capable of being, and someone doesn't see that same vision for them, you feel like you want to be there with them forever, but you can't. It's like any other child that you have to let them go. It's hard to let somebody go when they have a problem.
We've had the conversation, my parents and I, that if something were to happen to them, like, would I be okay with taking him on? And, I've come to terms with that, and I absolutely would. There's a possibility that, maybe Uncle Brett living in the studio apartment downstairs or something like that.
He runs out of things to do in his free time.
Sometimes making friends is hard to do. You can't find the right person to get along with. I'm struggling with trying to move out and find another job, and I'll be able to work full-time. I can get my own place, and once I'm on my own, I'm happy.
I finally found Emory had a autism center, which I never knew before.
The Emory Autism Center Nightlife program was specifically designed to begin to meet the needs of young adults on the spectrum.
One of our groups is the Nightlife group, and it's for individuals 25 to 35 years of age, and that's where we are tonight. Each Monday night, we're in this apartment, we're cooking, we're having activities, games, anything that we can do to help foster social interactions. We're going to see which group can remember the most about each other. There are not a lot of programs like this. More are coming out.
We do activities and plan meals and create projects to do. It's really, really fun. It helps you get together with people and you do things.
It helps me with social skills. It also helps me communicate better with my parents and stuff like that.
Being with other people around my age, trying to meet acquaintances or friendships.
I got people's numbers and stuff, and we talk about our interests, and it's helping me sharpen to understand them better and understand the world's perspective better.
In the field, we're fond of saying if you've met one person with autism, you've met one person with autism. People with autism are every bit as variable as people with brown hair. When we see, for example, folks in the program exchanging cell phone numbers so that they can get a hold of each other when they're not in the session, well, that's a success if a person's made a friend.
I worry about Brett's future a little bit. I just kind of have high expectations or high hopes for him.
Well, in 10 years, I would hope he would be on his own, have his own place, and have a full-time job that he likes.
I hope for him to have a part of his dream and a friend.
Yeah.
Yeah, at least one good friend.
I think I will be on my own. I'll be completely successful, and I think I might raise a family, and I think my life will be just fine. I'll be a successful person.
All right, so now we're going to have another video about autism, living with autism as an adult. So just like we saw in that last video, there's a lot of challenges involved, but that doesn't mean that there's no hope. It doesn't mean that there's no possibility to live a life integrated with society from a neurodiverse perspective. So I'll go ahead and we're going to play this video right here. Then once it's done, I'll come back in and we'll talk about it.
My name is Jason Shi and I'm 21 years old.
My name is Robin Jesse and I am 26 years old.
My name is David Dewar. I'm 28 years old.
I am diagnosed with level 2 autism.
Asperger's, OCD, and ADD.
The reason why I'm here is to learn social skills. It's because I often see myself as being socially inadequate, and I came here so I can learn all the various skills I need to be socially successful.
Meet the young, eligible, and autistic. They're smart, sweet, and funny, and keen to snag that special someone. Only problem, they don't have a clue how to do it.
This week, we're going to learn more about romantic relationships.
You see, when it comes to social skills, these 20-somethings just weren't born with them. So they've come to learn social cues that are second nature to most of us, but are foreign to the autistic brain. At a course that's proving what seems innate can be learned.
So that was very good.
Michael Barrett teaches the Peers program here in Calgary.
All right, great, time out. Teaching Peers, in a way, is kind of sort of like teaching a foreign language. What the Peers program tries to do is help them to learn to speak that language, and through a language that they understand. We want to be able to practice giving a courtesy laugh because.
And it starts with the very basics, stuff that most of us do naturally, like knowing when you're supposed to laugh at a joke.
To get to the other side.
Nice, good job.
Some of the social norms and techniques that other people just kind of pick up on, I've had to explicitly learn.
My brain isn't so developed to handle social interactions.
Have you ever asked anyone out on a date?
No, not at all.
Do you want to?
Oh yeah, definitely.
It's hard for Paul Gates to carry a regular conversation, let alone make romantic repartee. The 23-year-old lives with his parents in Strathmore, Alberta. He spends a lot of time helping his dad in his machine shop.
There you go. You know what to do.
Yep.
That keeps him busy and helps with the isolation. But like other young men his age, he wants more.
How do you feel about the whole idea of dating?
Well, it feels like I should start while I still can.
Why?
I don't know, so I can meet the right kind of girl who's into me and who I'm into more.
But to get the girl, Paul needs to, well, talk more. Linda Gates is his mom.
Sometimes if you know, you're talking to Paul and you might say, "So did you go to Calgary today?" Yeah. But he would never say, "Yeah, I went to Calgary today because we went to the Peers program and we went for dinner first." He doesn't elaborate. So, you know, the Peers program is really good at teaching them to sort of elaborate on their conversations.
I agree with you, David. It doesn't look natural. So what we want
Emotions,
to be able to do
tone of voice, facial expression can be baffling to read if you're on the spectrum. Peers teaches them how to start a conversation.
Hey, Marian.
Hi, Jason. How are you?
I'm good. How are you?
How to make a friend.
I think I met your friend the other day, Jane, I think.
Oh, yeah, Janie. Yeah.
And the trickiest of all social interactions, the ABCs of dating.
So one of the things that I would like for us to practice is just quickly going around the room and practice flirting with your eyes. So making eye contact, looking away, making eye contact, looking away. Robin, you're up. Good job. Good work.
The students practice with volunteer coaches.
We good?
Excellent.
Yeah.
Good job.
High five.
All right. Good job.
The key to all of this is practice, a lot of it.
The first thing is choosing appropriate people to date,
So down the hall, parents are learning how to drive the weekly lessons home.
and not everyone that is nice to you is flirting with you or wants to be in a relationship with you. So that's an important distinction that they're making over there.
They're acutely aware there's a lot at stake.
We know the research shows that individuals who do not establish good social foundation or a good social network later on in life run risk of a gambit of mental health concerns, isolation, depression, anxiety.
You seemed a little bit more connected this week.
A lot of parents come to us and they're really worried about, what's going to happen to my son or daughter, when I reach retirement or when I'm gone. We have so many children who come in and it's like, well, why would I connect with anybody because I have mom and dad?
Okay, so you call Joe and see what Joe's up to, Paul.
But mom and dad are not always going to be there. So Paul's homework is that much more important.
Hey, Joe. Hi, Paul. How are you? Oh, good.
Today, it's to call a family friend to just have a chat. A small step, but critical for Paul to learn how to expand his social network.
Might want to ask how the kids are, Paul.
How are the kids? Really?
With prompts from his mom, he's encouraged to keep the conversation going.
See ya. Bye.
What are you envisioning in your mind?
Oh, mainly having good friends. And a girlfriend, too. That's mainly what I got in my mind almost every day. A girlfriend who just loves me for who I am.
And who are you?
I'm just a simple guy just trying to live out his regular everyday life.
As a mom, what do you ultimately hope? What do you want for your son?
I want the same as everybody else wants for their sons. I want them to be happy. I want them to be, I want them to have a good social life. I want them to be happy in whatever job or whatever he's doing at the time. And that's all. I don't want anything more for him than anybody else wants for their child.
Paul, what's another general comment? I'm so funny. You're absolutely right. I am so funny.
But it's harder for these young people to know how to go after that happiness. The simplest of things have to be broken down, painstakingly broken down.
What could be the problem with staring at a person for too long?
You'll look like a stalker. You'll harass them.
Okay.
They think that you're just.
You're absolutely right.
You're socially inept.
They might think you're a creepy stalker. Yeah. So instead, what we want to do is maintain casual eye contact.
It's a social toolkit that can change their lives.
Many come back with that aha moment saying, hey, you know what? I practiced some of these skills and I found that the results are different. So that was their wake-up call.
Duncan Thorpe is living proof that the program works. He graduated from Peers last year. Quite simply, it changed his life. He has a job to get to every day.
Hey guys.
And is getting the hang of being more social.
Normally, I would just keep it at a very narrow comfort zone. And as I socialized more, it kind of, even after the program, I feel that it's just expanding my comfort zone.
Yeah. Laura Thorpe says her son is a different person.
The biggest thing I've seen is confidence. His confidence is enormous now. I mean, he's, I can do this. Those are the words that come out of his mouth rather than, I don't know what to do. Like he would just shrink away.
Next meeting is...
And Duncan's proudest achievement? A girlfriend. Make no mistake, it's still a work in progress.
You have to remember, don't monopolize the conversation.
Linda has to remind her son about the rules of dating, but he's in the game.
Are you a better boyfriend now?
Yeah. If anything, like it's only increased how my girlfriend feels towards me, and she's, if anything, she's just amazing.
Duncan and Brittany Morrison are like any young couple in love. They've only got eyes for each other. Only now they tell that to each other more often. Brittany is also on the spectrum.
So are you guys happy together?
Definitely. Like there's not a day where we just don't want to see each other. Like each time I think about it, like it just makes me want to see her as soon as possible.
And what does Brittany think?
What? How about you?
I am very, very happy.
Is he a keeper?
Yes. I can't believe I got him on my first, the second try of the dating thing. Seriously, a guy like this that's not that bad to look at, has a great personality. Freaking lucky.
Let's face it, a romantic dinner may not be in the cards for every Piers grad, but you can't help rooting for all of them to get here because they're so achingly honest, so without game or guile.
Excellent. Good job, guys. Round of applause.
It's that time of life when I'm expected to date. I feel like I would missed out on a very important part of life.
No one can live alone. Well, at least not alone forever.
Why is it important for you to meet someone?
So I can have the time of my life with them.
And learning to speak the language of love may just bring them all closer to that happy ending. Joanna Rumiliotis, CBC News, Calgary.
All right, so there we go. We saw some similar themes in that video and some of the prior videos. So for example, we see themes about dating, sexual relationships, educational attainment, vocational success. So as you see right here, there are some difficulties involved with being on the spectrum, but it doesn't preclude you from living a life that is satisfying and fulfilling. So as we see here, there's a lot of ways that individuals on the spectrum are marginalized in society or thought that there are certain mile markers they can't achieve. There's a show on Netflix called Dating on the Spectrum. I think it's on Netflix. Not really from a clinical perspective is the best show, but it has really good, narratives of people's lived experiences. So if you're interested in seeing more about how individuals on the spectrum approach relationships and dating, that's a good show to watch. And also to kind of opens up your mind and opens up your experiences of what you think is possible for individuals on the spectrum. Or maybe you've already known this and you've already believed this, or maybe this is the first time you're hearing about this. But, individuals who are on the spectrum have every, right, and they should have the ability to achieve the life that they desire. All right, so that's going to be the end of our lecture for today. I would encourage you to send me an email to come to office hours, ask me any questions that you might have. Make sure that you watch the videos that I posted on the Study Video Folder and Compass. If you have any questions, once again, email me, let me know what's going on. Make sure you study for the quiz. Make sure you're doing all your work. And if you need any help, just go ahead and reach out. And if within reason, I should be able to help you. All right, everybody. So that's going to end the lecture. All right, take it easy. Peace, peace, peace.